running through here and just checking on the curve, on the scoliosis. And just tip your head up a little bit for me. Is that comfortable?
Yes.
That's fine. Just hold it there. Just have a look. Have you had any leg pains this week? Diagnosis and evaluating the patient is the most essential factor. Okay, that's fine. Just going to move you a little bit just to see whether you're fairly balanced. Are you getting any dizziness or anything? We ensure that the patient falls within the parameters of osteopathic treatment. We have to ensure that we don't have to communicate with the GP to make sure that there are other underlying causes which need to be treated as well. Okay, I'd like to have a look at your walk now. So if you can nice and slowly walk up to the window, and then when you get there, just turn round and come back towards me. Once we're aware that the rest of the field is clear, we can carry out our osteopathic techniques to make them comfortable in whatever condition they've come in with. We don't touch the patient as such, we don't treat it until we've taken a thorough history. We're comfortable in knowing that what they've told us is A, the truth, and B, the full story. On a personal basis, if I'm not sure, then I will communicate with their GP to make sure that I get a full history of what medication they're on, what operation they've had, and any other relevant medical history. Now, I'll just be looking at you, Kim, just to see how your curve changes have occurred in the last few weeks since I've seen you last. First of all, I'm interested in seeing how much you've got bigger here and the effect it's had on the lower back. So just stand nice and comfortably. Even if you're slouching, don't worry. That's fine. So you can see
a recent government report from the Independent Clinical Standards Advisory Group has recommended that general practitioners should draw more widely on the services of physical therapists like osteopaths. But involving an osteopath, someone outside our direct discipline, in the management of one of our own patients isn't something we do lightly. It is, however, something which is becoming increasingly relevant. We can't, for example, do much about the majority of patients who visit our surgery complaining of back pain, but in a large number of cases, an osteopath can. And of course, a successful treatment can have a positive effect on the practice's workload. So how could this shared care approach work? What are the medico-legal implications? And if we're to trust our patients to an osteopath, what's the level of competence we should expect? Just as important, which patients should we refer? This is the first of two programs on this subject in which we set out to answer those very questions. We'll be meeting osteopath Emanuel Sammut and looking at the treatments received by two patients, one suffering from lower back pain and the other from a whiplash injury sustained during a car accident.
Good. Well done. That's it.
To the uninitiated, and I'm certainly that, there's some confusion as to the difference between an osteopath and a chiropractor. So I began by asking Emanuel to explain.
Their philosophical standpoint tends to be that they look at a structure, they look at the position of one vertebra in relation to the other, whereas our standpoint is more on function. We're quite happy with a curved spine as long as it works properly. So I would look at a patient, does he function properly? A chiropractor may take the point, is his structure correct? So that's a basic philosophical difference.
Doctors use x-rays, physiotherapists use infrared treatments, and they also use vibration. Sometimes they use acupuncture. What do osteopaths use?
Three main tools: our hands, our ears, and our eyes. We listen to what the patient has to say, we observe their movements, we observe them when they're talking to us, we observe the way they move, they get dressed, undressed, when they get onto the plinth, and then we use our hands to actually carry out and execute the treatment techniques. Just some oscillating movement there.
Although I spent a whole day with Emanuel, not only talking about his work, but also observing him as he assessed and treated a number of patients, including an elderly lady suffering from osteoporosis and, surprisingly, a healthy young pregnant woman, it took very little time to appreciate his professional competence. But some GPs I know are unused to thinking of osteopaths as trained professionals and are therefore somewhat reluctant to refer their patients to them. But is that reluctance justified? How good is their training? Emanuel is the ideal man to tell us about that too, because apart from being a practicing osteopath, he also lectures once a week at the British School of Osteopathy, the oldest of its type in Europe.
So it's a lifestyle-threatening aspect we're looking at and not the life-threatening aspect. And you've got to try and put it into context with the patient. The training is a 4-year full-time course, which at the moment leads to a BSc honours degree. It used to be a diploma course, so many osteopaths on the field at the moment still have the diploma qualification. Primarily, we do a lot of basic medical training. We have doctors teaching medical part at the British School of Osteopathy. We have practitioners in the field, osteopaths teaching the osteopathic side, the manipulative side, the philosophical side, and the actual technical side to it. Some of the course is carried out at other universities in London. but most of the training is actually done at the British School of Osteopathy.
And you also do dissection, I understand?
We do, yes.
When we were talking earlier on, you told me that diagnosis is very important in an osteopath's training.
Diagnosis and evaluating the patient is the most essential factor, because then, A, we ensure that the patient falls within the parameters of osteopathic treatment. We have to ensure that we don't have to communicate with the GP to make sure that there are other underlying causes which need to be treated as well. And then once we're aware that the rest of the field is clear, we can carry out our osteopathic techniques to make them comfortable in whatever condition they've come in with.
I think that's very important because GPs have a great fear of referring to somebody who's just going to treat without actually trying to find out if there's anything really wrong with the patient.
Yes, we don't touch the patient as such, we don't treat until we've taken a thorough history. We're comfortable in knowing that what they've told us is the actual, A, the truth, and B, the full story. Once we've established the nature and character of the symptoms, what do we then want to know in the early stages? What do we need to know?
The degree course at the British School of Osteopathy provides the students with an excellent understanding of anatomy and physiology and the therapies which are essential to an osteopath. But it also encourages them to consider themselves one of a team working hand in hand with other healthcare professionals such as ourselves. So how does that work out in practice? Dr. Sanjit Sekhan is a GP in Walton-on-Thames who's referred many patients to Emanuel.
What sort of patients do you refer to him and what criteria do you use?
Well, I have been sending mainly musculoskeletal problems such as lower back pains and neck pain, but more recently I've been sending him conditions such as tennis elbow, migraines. I believe that he's able to undertake a wide variety of treatments for a wide variety of conditions, and but at the moment they're fairly confined to those, but they will be increasing in the future.
Do you have a go at them yourself first? Do you use non-steroidals or injections or whatever before you think of sending them on?
Yes, it depends on the patient. After my initial assessment, I will reassure the patient. Some of them will have non-steroidals, some are keen to actually go straight to an osteopath. I do acupuncture myself, I will try that sometimes. But on the whole, after an assessment, and if I think it's appropriate, I will send them to Emanuel.
What cases would you send straight away?
Mainly back pains that I'm happy that are of musculoskeletal origin, whiplash injuries, Rhinex. Those are the main ones that I would send straight away, but as long as in my consultation I was happy that there was nothing else going on or there wouldn't be any other appropriate treatment, I would send them straight to him.
I guess working with an osteopath demands communication of a different sort of order than we normally see within the NHS. How do you find that works in practice?
Well, it works very well. I will normally give my patients Emanuel's phone number and they will phone him directly. Now and again I will write him a formal letter outlining the history, the parts of the investigations that have already been done and any previous treatments that he's had. What's also very important is the communication of the osteopath back to myself. In Emanuel's case, he will often phone me or write me a letter with his findings, his diagnosis, and the treatment that he's given. And that's very important from my point of view because it means that I know exactly what's happening with the patient. I also know if Emanuel's not happy with the situation, whether we need to look elsewhere for treatment or investigation, and also enables us to keep our safety net of communication that we all rely on.
One of the patients that Dr. Sekhan referred to Emanuel Sammut was John Selly, suffering from lower back pain.
The significant features: he had a hip replaced in '85. He's got a long history of arthritis, both family history and personal history. He's had a prolapsed disc at L5 and has had recurrent aches and pains in the spine and in lower extremities as well.
How did you assess him?
Primarily we had to take a thorough history to make sure we weren't missing any important points. I'm seeing him with his GP, so his GP came armed with all his relevant medical history. His main assessment has been in his posture, his standing posture and his sitting posture. To start with, I'd like to see his weight bearing, so I would look at him from the side. We can see in this case it's quite posterior weight bearing. If I was to just gently tip him backwards, he would fall. It'd be quite unstable, whereas he would quite comfortably travel forwards, indicating that most of his weight bearing is quite posterior. Now, to look at him from behind, if you could just turn to face the window for me, John. That's great. Just a little bit here this way. We can see, just let him settle down a little bit. There's a wider gap on this side than there is on here. His hand is tucked in there, which means he's thrown his weight more to the left. That's an indication that we have a shorter lower extremity there, which can be confirmed when the patient's lying down. Now, if we look at, there's quite a high increase in tone on the posterior spinal muscle there, the postural muscles, and if we can just ask him to just bend forwards, there's very little movement really in the spine. A lot of it is coming from just the occasional area there. His spine is quite rigid. Is that painful, John?
Yeah, that's all right so far.
And come up. Now, I would expect with a gentleman having had the hip replaced, I would expect more hip movements. He's still relying a lot on just some key areas of the spine, and the aim of the treatment is going to be to redistribute his workload on the spine by moving certain parts which at the moment are not doing much work. If we can just turn to face me. In the long-term management, I'd like to have somebody look at his feet. We can see here his arches have collapsed, particularly the left side on there, and he's getting quite flat on that side. Now, any long-term changes I will make to his spine, his weight bearing, will have to be supported by some orthotic support, so I would suggest that John will visit a podiatrist to rectify that for him. Okay, I'd like you to just lie on your side for me now on the treatment table. My main area of interest in this particular patient when he's lying down is to see how much or how little movement there is in the lumbar spine and thoracolumbar area. Because of his posterior weight bearing, I want to make sure that his facet joints are not taking too much workload, and the x-rays had actually shown us some degenerative changes there. So passively I'm just introducing some ranges of movement to ensure that there aren't too many joints doing too much of the work. Is that painful? You okay? Painful? You're all right. Okay, I'm still assessing at the moment. I want to see what's happening to the lumbar spine, so I would use his lower limbs to introduce the leverages. I'll just bend your knees for me, John. That's fine. No? Is that okay on the hip? Just some oscillating movement there. It's just going to introduce. Okay. Now this is a site where he had the prolapse disc. He's had a prolapse disc in the past, L4-5 and L5-S1. It's very tender because there's a lot of excessive activity there. The disc has degenerated over the years and he's left a lot of muscular activity. So that's an area that I would like to improve in mobility by making the upper lumbar area work a little bit more than normal. So keeping him in that position, so we've got the lumbar spine flex, I want to introduce some rotation a little bit higher up, just still assessing what's going on. Now, as we're still in the early stages of treatment with John, well, rather than to actually manipulate the joints, I'm more interested in relieving some of the symptoms, and that can be done by taking some of the stretch of the soft tissues. I'm just going to roll you forwards a little bit. I'm just applying a longitudinal stretch just to open up the foramina there and to start introducing stretch to the soft tissues such as the tendons, the muscles, the ligaments, and make sure the foraminal areas are as wide as possible to take any neurological pressure or any pressure off the neurological structures such as the emerging nerve roots. Is that okay? The progressive management of a case like this would be to, once we've got some better soft tissue turns, some more relaxed muscle states, then I can start introducing some manipulative techniques to increase the range of movement of any isolated joints. But that would have to be done once I'm sure that these soft tissues are a little bit more relaxed. If you could roll on your back for me, John, I'd like to just show your feet. Take your time, that's fine. Lift your head. I can see here the feet and the ankles, there's quite an excessive movement on there. So there's a lot of laxity of the ligaments here, which really they're beyond physical repair as such, which is why I'm suggesting that he sees a podiatrist to just introduce a foot support in there to just re-establish some normal alignment of the ankle joint, so that then his lower limb, his leg and his pelvis and his spine would start to sit properly on the foot. So otherwise we'll have this tendency to turn out all the time, so he'll splay his hip out as well, which will upset the balance of the whole spine.
Sanjit, let me ask you, what do you think it is that osteopathy's got to offer patients that traditional medicine hasn't?
Well, traditional medicine can offer analgesics, non-steroidal anti-inflammatories, epidural injections by consultants, but I believe that a lot of musculoskeletal problems have a biomechanical abnormality, and the osteopath would seem the appropriate person to make the assessment. And also he's able to make a more global structural and functional assessment, which would be needed in these patients.
And Emanuel, would you agree with that?
I would. I'm very keen on his application of the term global, whereas we will look at the whole patient rather than just their problem. So yes, I'd agree with a little addition.
John, you're the customer, you're the patient. What do you think of the care you're receiving from your two professional advisors?
Well, as my advisors know, my problems started 8 years ago. They've been extremely unpleasant. I'm very grateful to traditional medicine, which gave me a hip replacement, but it hasn't cured my back. At the moment, after a certain amount of treatment, I begin to feel hope. The first time I've felt hope in 8 years, despite non-steroidal anti-inflammatories, painkillers, etc. My quality of life has improved. My energy is improving.
So both the healthcare professionals, and even more important, the patient himself, are happy with this shared approach. And as we see an awful lot of back problems of this nature in our surgeries, the lesson would appear to be a simple one.
It's very important that you know the practitioner, perhaps have been round to the premises themselves and had a look round, and perhaps even looked at or sat in on some sort of sessions that the osteopath may do.
Well, if you didn't before, I hope you will now have recognised that the osteopath is a highly trained professional into whose care we can reasonably refer those of our patients who are suffering from musculoskeletal problems. But shared care requires an understanding of one another's roles, so get to know your local registered osteopaths. Like us, they're all individuals with strengths, weaknesses, likes and dislikes. But if we can work together, it will bring benefits to all concerned.
After a certain amount of treatment, I begin to feel hope. The first time I've felt hope in 8 years, despite non-steroidal anti-inflammatories, painkillers, etc. My quality of life has improved. My energy is improving.